multinational pharma companies to be sole market authorization that allow innovative molecules up to 10 years monopolies that strictly apply. The patent laws are not fully enforced and remain notably below the international standards, aiming to be in the patient's favour side. Regarding low purchasing power, Egyptian population below poverty line are 25% national standard. Pharmaceutical sales per capita are $26.2 US, which is very low compared to neighbour countries below poverty line. Socio-economic class who can't afford the brands of innovators. 70% of healthcare expenditures are out of pocket, i.e. patients cover most of their medication bill. How does it feel when the patient gives up the treatment just because of the unaffordable prices? That's how bad the Egyptian patients feel. It's clear that there is a gap in the Egyptian pharma market. The role of the local national companies is to on fixing this gap by offering affordable, innovative medical solutions without sacrificing the quality aiming to maintain our community healthy and enjoying well-being. That is why Inspire exists. That's why Inspire Pharma created its medication as a sample of millions that will be manufactured with care, where we see the patient behind the disease to fill in the gap between innovation, quality, and affordable prices. Relying on the ethical behavior, innovation, quality, and professionalism. We have aspiration to position Inspire as one of the top 5 pharmaceutical organizations in the Middle East region within 10 years. Inspire milestones, total sales evolution, company growth pattern, sales and headcount year over year. We build our company as a brand for innovation and excellence in the pharmaceutical market. The first medication has been into the market since 2005, when we attracted lots of talents to serve, achieving the desired Inspire goals. Then, 15 molecules were launched successfully since 2010. These medications contain innovative medical solutions for different pharmaceutical fields. We are committed to meet the pharmacopoeia and in-house standards for all our products to supply consistent quality that exceeds customer requirements. We are focusing on A. Materials sourcing. Share updated approved supplier database. Being updated by attend global CPHI exhibitions. Professional technical discussion with suppliers. B. Bioequivalence study. Stick to FDA guidelines. Currently, we are operating in 6 business units. CNS line, Gyn and Rheuma line, Diabetes line, Cardiovascular line, Hospital line, HCV line. We are proud to be your partner in helping reduce burden of illness among Egyptian community by offering up-to-date, innovative medical solutions with consistent high-quality standard at affordable prices. Millions of medications are being manufactured every day, but this one has a reason of existence. Unlike other medications, it has been called out by the existing unfulfilled need of the Egyptian patients. However, Egypt is one of the most populous countries in the Middle East, the second largest pharma market size in MENA region, the oldest medical school in the Middle East. However, Egyptian pharma market is unique in nature. Why? 70% of the Egyptian patients are out of pocket, suffering the lower income. Moreover, the delayed patent law. Regarding patency law, other countries that strictly apply patency law could keep exclusive right to multinational pharma companies to be sole market authorization holder that allow innovative molecules up to 10 years monopoly. Luckily, the patent laws are not fully enforced and remain notably below the international standards, aiming to be in the patient's favor side. Regarding low purchasing power, Egyptian population below poverty line are 25%. Pharmaceutical sales per capita are $26.2 US, which is very low compared to neighbor countries. Socio-economic class who can't afford the brands of innovators. 70% of healthcare expenditures are out of pocket, i.e. patients cover most of their medications bill. How does it feel when the patient gives up the treatment just because of the unaffordable prices? That's how bad the Egyptian patients feel. It's clear that there is a gap in the Egyptian pharma market. The role of the local national companies is to on fixing this gap by offering affordable, innovative medical solutions without sacrificing the quality, aiming to maintain our community healthy and enjoying well-being. That is why Inspire exists. That's why Inspire Pharma created its medications as a sample of millions that will be manufactured with care, where we see the patient behind the disease, to fill in the gap between innovation, quality and affordable prices. Relying on the ethical behavior, innovation, quality and professionalism. Our vision. We have aspiration to position Inspire as one of the top 5 pharmaceutical organizations in the Middle East region within 10 years regarding Inspire milestones, total sales evolution, company growth pattern in sales and headcount year over year. We build our company as a brand for innovation and excellence in the pharmaceutical market. The first medication has been into the market since 2005, when we attracted lots of talents to serve, achieving the desired Inspire goals. Then, 15 molecules were launched successfully since 2010. These medications contain innovative medical solutions for different pharmaceutical fields. We are committed to meet the pharmacopoeia and in-house standards for all our products to supply consistent quality that exceeds customer requirements. We are focusing on A. Material sourcing. Share updated approved supplier database. Being updated by attend global CPHI exhibitions. Professional technical discussion with suppliers. B. Bioequivalence study. Stick to FDA guidelines. Currently, we are operating in 6 business units. CNS line, Gyn and Rheuma line, Diabetes line, Cardiovascular line, Hospital line, HCV line. We are proud to be your partner in helping reduce burden of illness among Egyptian community by offering up-to-date, innovative medical solutions with consistent, high-quality standard at affordable prices. Millions of medications are being manufactured every day, but this one has a reason of existence. Unlike other medications, it has been called out by the existing unfulfilled need of the Egyptian patients. However, Egypt is one of the most populous countries in the Middle East, the second largest pharma market size in MENA region, the oldest medical school in the Middle East. However, Egyptian pharma market is unique in nature. Why? 70% of the Egyptian patients are out of pocket, suffering the lower income. Moreover, the delayed patent law. Regarding patency law, other countries that strictly apply patency law could keep exclusive right to multinational pharma companies to be sole market authorization holder that allow innovative molecules up to 10 years monopoly. Luckily, the patent laws are not fully enforced and remain notably below the international standards, aiming to be in the patient's favor side. Regarding low purchasing power, Egyptian population below poverty line are 25%. Pharmaceutical sales per capita are $26.2 US, which is very low compared to neighbor countries. Socio-economic class who can't afford the brands of innovators. 70% of healthcare expenditures are out of pocket, i.e., patients cover most of their medications bill. How does it feel when the patient gives up the treatment just because of the unaffordable prices? That's how bad the Egyptian patients feel. It's clear that there is a gap in the Egyptian pharma market. The role of the local national companies is to on fixing this gap by offering affordable, innovative medical solutions without sacrificing the quality, aiming to maintain our community healthy and enjoying well-being. That is why Inspire exists. That's why Inspire Pharma created its medications as a sample of millions that will be manufactured with care, where we see the patient behind the disease, to fill in the gap between innovation, quality, and affordable prices. Relying on the ethical behavior, innovation, quality, and professionalism. Our vision. We have aspiration to position Inspire as one of the top 5 pharmaceutical organizations in the Middle East region within 10 years regarding Inspire milestones, total sales evolution, company growth pattern in sales and headcount year over year. We build our company as a brand for innovation and excellence in the pharmaceutical market. The first medication has been into the market since 2005, when we attracted lots of talents to serve, achieving the desired Inspire goals. Then, 15 molecules were launched successfully since 2010. These medications contain innovative medical solutions for different pharmaceutical fields. We are committed to meet the pharmacopoeia and in-house standards for all our products to supply consistent quality that exceeds customer requirements. We are focusing on A. Material sourcing. Share updated approved supplier database. Being updated by attend global CPHI exhibitions. Professional technical discussion with suppliers. B. Bioequivalence study. Stick to FDA guidelines. Currently, we are operating in 6 business units. CNS line, Gyn and Rheuma line, Diabetes line, Cardiovascular line, Hospital line, HCV line. We are proud to be your partner in helping reduce burden of illness among Egyptian community by offering up-to-date innovative medical solutions with consistent high-quality standard at affordable prices. Millions of medications are being manufactured every day, but this one has a reason of existence. Unlike other medications, it has been called out by the existing unfulfilled need of the Egyptian patients. However, Egypt is one of the most populous countries in the Middle East, the second largest pharma market size in MENA region, the oldest medical school in the Middle East. However, Egyptian pharma market is unique in nature. Why? 70% of the Egyptian patients are out of pocket, suffering the lower income. Moreover, the delayed patent law. Regarding patency law, other countries that strictly apply patency law could keep exclusive right to multinational pharma companies to be sole market authorization holder that allow innovative molecules up to 10 years monopoly. Luckily, the patent laws are not fully enforced and remain notably below the international standards, aiming to be in the patient's favor side. Regarding low purchasing power, Egyptian population below poverty line are 25%. Pharmaceutical sales per capita are $26.2 US, which is very low compared to neighbor countries. Socio-economic class who can't afford the brands of innovators. 70% of healthcare expenditures are out of pocket, i.e., patients cover most of their medications bill. How does it feel when the patient gives up the treatment just because of the unaffordable prices? That's how bad the Egyptian patients feel. It's clear that there is a gap in the Egyptian pharma market. The role of the local national companies is to on fixing this gap by offering affordable, innovative medical solutions without sacrificing the quality, aiming to maintain our community healthy and enjoying well-being. That is why Inspire exists. That's why Inspire Pharma created its medications as a sample of millions that will be manufactured with care, where we see the patient behind the disease, to fill in the gap between innovation, quality, and affordable prices. Relying on the ethical behavior, innovation, quality, and professionalism. Our vision. We have aspiration to position Inspire as one of the top 5 pharmaceutical organizations in the Middle East region within 10 years regarding Inspire milestones, total sales evolution, company growth pattern in sales and headcount year over year. We build our company as a brand for innovation and excellence in the pharmaceutical market. The first medication has been into the market since 2005, when we attracted lots of talents to serve, achieving the desired INSPIRE goals. Then, 15 molecules were launched successfully since 2010. These medications contain innovative medical solutions for different pharmaceutical fields. We are committed to meet the pharmacopoeia and in-house standards for all our products to supply consistent quality that exceeds customer requirements. We are focusing on
بسم الله الرحمن الرحيم. بالنيابة عن شركة إنسباير فارما وزملائي بشكر جمعية العظام المصرية، جمعية جراحة العظام المصرية والسادة الحضور سواء كان من داخل جمهورية مصر العربية أو من خارجها على السماح لنا بهذا الوقت الثمين اللي في هذا السيشن العلمي اللي يقوده كوكبة من علماء مصر والعالم في مجال جراحة العظام المصرية. يشرفني طبعا ان يكون ده يعني سيشن من سيريز بدأتها جمعية العظام المصرية على مدار الثلاث أسابيع الفائتة، وإن شاء الله تكون النهاردة يعني آخر سيشن في هذه السيريز، وتكون مثمرة كالعادة كما تعودنا من جمعية العظام. يعني أنا بثني كثيرا على المجهودات اللي بيبذلها جمعية العظام المصرية متمثلة في رئيس الجمعية الأستاذ الدكتور جمال حسني. الحقيقة الجمعية أنا يعني لنا علاقة طيبة بها من أكثر من 20 سنة على المستوى الشخصي، لا تكل ولا تمل على رفع المستوى الطبي لكل يعني أطباء العظام سواء في مصر أو في العالم العربي أو حتى خارج الحدود في دول أوروبية وفي أمريكا وشمال ودول آسيا. الجمعية مثال يحتذى به لكل الجمعيات الطبية. يعني أنا حتى لا أطيل عليكم ونبدأ هذا اللقاء المثمر، أترك الميكروفون لأستاذي والأستاذنا ورئيس جمعية العظام المصرية الأستاذ الدكتور جمال حسني، فليتفضل. يعني تفضل يا دكتور.
شكرا دكتور مصطفى. طبعا بسم الله الرحمن الرحيم. طبعا أنا يسعدني ويشرفني طبعا إن احنا نقدم هذا الويبينار اللي هيقوم به طبعا كوكبة من الزملاء الأعزاء الخبراء في مجال جراحة عظام الأطفال. في البداية طبعا بحب أشكر شركة إنسباير. شركة إنسباير فارما طبعا شركة من الشركات اللي ليها باع طويل في مجال صناعة الدواء الحقيقة، وإحنا بنثق في المنتجات بتاعتها ثقة كبيرة جدا. وبيسعدني طبعا يكون النهارده على رأسها زميلي واخي العزيز دكتور مصطفى هناوي. طبعا هو عشرة عمر معايا من زمن الزمن، بس هو شباب طبعا عني بكتير، يعني مش فرق كبير كده طبعا. المهم طبعا شركه انسباير طبعا بنشكرها تماما لانها بتسبورت الكثير من الاكتيفيتيز لجمعيه جراحه العظام المصريه. طبعا شركات الادويه ليها دور مجتمعي كبير في ان هو تساهم في التعليم الطبي المستمر، وده الهدف الاساسي لجمعيه جراحه العظام المصريه. التعليم الطبي المستمر الحقيقه مش بيخدم بس الاطباء، هو في واقع الامر هو خدمه للمرضى اساسا، لان كل ما الطبيب مستواه ارتفع طبعا كل ده ما بيؤدي الى خدمه احسن واحسن للمرضى. كما احنا عارفين طبعا ان علمنا علم متغير، كل يوم بيبقى فيه شيء جديد. فالتعليم الطبي المستمر اللي هو على عاتق جمعيه جراحه العظام المصريه خدته على عاتقها في غايه الاهميه. مش هطير عليكم طبعا. في البدايه انا احب طبعا اقول اشكر الزملاء الاعزاء وعلى راسهم استاذنا طبعا الاستاذ الدكتور خميس الديب، استاذ جراحه العظام كليه طب جامعه الاسكندريه، ورئيس جمعيه جراحه العظام السابق والحالي طبعا مش عايز الكلام، ورئيس جمعيه جراحه عظام الاطفال. المصرية السابق. الدكتور خميس طبعا غني عن التعريف، هو معبود الجماهير طبعا، كلكم بتحبوه طبعا. الدكتور خميس ليه ايادي وباع طويل في مجال التعليم الطبي المستمر، والنهارده هيكلمنا على خبرته طبعا على مدار السنوات الطويله في مجال البيرث ديزيز. معانا طبعا الاستاذ الدكتور حسن البربري. الدكتور حسن البربري استاذ جراحه العظام بكليه طب القصر العيني، ورئيس وحده جراحه عظام الاطفال في كليه طب القصر العيني. الوحده دي طبعا هي اول وحده جراحه عظام اطفال في الشرق الاوسط، انشاها استاذنا الدكتور صالح بدير. استاذنا الدكتور صالح بدير استاذنا جميعا طبعا بلا جدال، وهو اللي ابتدى هذه الوحده، وابتداها ب4 سراير. انا فاكر كويس قوي، برغم كان الحقيقه معارضه شديده من يعني اطراف كثيره، لكنه ابتداها وثابر في هذا المجال. وخير من يمثله طبعا الدكتور حسن البربري طبعا تلميذه الوفي، وهيتكلمنا النهارده الدكتور حسن على موضوع في غايه الاهميه، سليب كابيتال فيمورال ابيفيسيس. طبعا معانا النهارده الاستاذ الدكتور طارق حسن، استاذ جراحه العظام بطب عين شمس واستاذ جراحه عظام الاطفال. الدكتور حسن طبعا الدكتور طارق طبعا ليه باع طويل في مجال جراحه عظام الاطفال، وانا بقابله كثيرا جدا في المؤتمرات في الخارج وهو بيلقي محاضرات وابحاث كثيره في هذا المجال. وان شاء الله النهارده هيكلمنا على الدي دي اتش. ان شاء الله هنفتتح الويبينار بمحاضره الاستاذ الدكتور طارق حسن. دكتور طارق اتفضل يا فندم.
شكرا يا بيه. Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank the Egyptian Orthopedic Association, and in particular the head of the organization for inviting me to this webinar. I would also like to thank Inspire, a pharmaceutical company, for organizing the technicalities of this webinar. I would also like to express my deep respect to Professor Gamal Hosni for inviting me for this lecture. I will try and stick to the time, and I will try and make the whole presentation in English, so we might have audience from non-Arabic speaking countries. I shall talk about developmental dysplasia of the hip. I know that the audience might be of different levels of experience, so the lecture will vary sometimes from some basic knowledge to also some advanced knowledge. We all know that DDH is a condition in which the femoral head has an abnormal relation to the acetabulum. Any technical problems, Professor Khamis?
خلاص اوكي اتحلت.
Okay. Some of these findings may not be present at birth. That's why the term is developmental, more accurate than congenital. And because DDH, developmental dysplasia of the hip, will encompass frank dislocation, as in the top picture, sometimes only a partial dislocation or a subluxation, and sometimes just a dysplastic or a shallow acetabulum, that's why the term dysplasia rather than dislocation will be a more appropriate nomenclature. It is a relatively common condition. It is seen with variable incidence, but in the average of 1 in 1,000 live births. It's more common on the left side and in baby girls rather than baby boys. Now, one of the take-home messages of this lecture is who are the at-risk babies. We all know that the female firstborn child whose mother had DDH, I mean with a positive family history, is more likely to have DDH. And then also we know that twins or a baby born breech presentation or any baby born with any other associated deformity like clubfoot will be much more at risk having DDH. That's why if we examine the baby who parents have brought her with a clubfoot to examine a similarly grave mistake. So this is one of the take-home messages who are at risk for developing DH. Now, for such a condition, we need to be able to scrutinize this a little bit more. We have this can be done by the pediatrician will check the respiration and the clearance of the airway. The attending pediatrician should be able to do the ortolani and those tests. And it is our duty to train pediatricians. I have taught the pediatricians how to do these tests because they are the ones who are more likely to see these babies at the time of delivery and even to see them more frequently during the follow-up. Ortolani test is a relocation test. If the hip is dislocated, then by abducting the hip and pushing on the greater trochanter without the index finger, the hip will be reduced. Now, sometimes the hip is reduced, but it is unstable. So we do a provocative test, in which case we adduct the hip and push it backwards, and then the hip comes out, and then we then do the ortolani test again. Now, the second take-home message of my lecture today is that not any click that we hear is positive test. What we consider positive is a palpable click, what we call a clunk. So you hear it with your ears and you feel it with your hands. This is a positive test because just clicky hips may be caused very commonly by snapping iliotibial tracts. Now, the baby who is born with DDH, if we look at this picture, we find limited abduction. If we look at this picture, we have the shortening. And if we have bilateral cases, then we have an increase in the lumbar lordosis. Now, I will try and show these videos at the end, but the DDH does not cause delayed walking. This is another take-home message. DDH causes a limp, either a unilateral, in which case the baby sways the trunk to the dislocated side, what we call a Trendelenburg gait, or the baby sways the hip, the shoulders, and the trunk to either side, which we call a waddling gait. So DDH does not cause delayed walking. Now, how can we image? How can we confirm our clinical testing? Ultrasound has a lot of advantages. First, it contains non-ionizing radiation, and it will ossify the femoral head at birth because it is only cartilaginous, and we will not be able to see it by an X-ray before the age of 6 months. It has a few advantages. Many of them are just technical. First of all, it is operator dependent. So you need a trained musculoskeletal radiologist who knows how to do this ultrasound. The usual common method is the static technique that was described by Graf, in which case we have 3 lines. If we look at the picture, then we have the baseline, which represents the ilium, and then we have 1 line that represents the labrum, and then we have 1 line that represents the acetabular roof, and between them we have the angles, just like we have here. So if we look at this line, this is the labral line, this is the iliac line, and then this line will represent the labrum, and this will represent the acetabular roof. The alpha angle will represent the bony acetabular coverage, and the smaller the angle, the more the dysplasia, but the beta angle reflects the coverage by the labrum, and the more the angle, the more dislocated it is. And this is one of the very classic pictures. I mean, all the angles and all what I have said before might be very confusing, but if you train your eyes to look at this picture and mark you, if you ask for an ultrasound and you don't get this picture in which there is the inverted Y appearance with the stem of the Y represented by the ilium and this line represented by the labrum, this line represented by the acetabular roof, and then the femoral head in between circle with white dots which represent the starting ossification. If you don't get this picture, then don't trust this ultrasound because it is being done by a non-trained radiologist. So we can all appreciate whatever the angles are because these angles have a very inter and intra-observer reliability sometimes depending on where you put your dots. but you cannot miss that this hip is dislocated. It is not lying in the center of the inverted Y like this one. So definitely this is a dislocated left hip, and this is a contained right hip. This is the hip that we are talking about that really needs treatment. I won't waste time in this slide because it is in all the books with the different types of the graph, but what I want you all to remember is the normal hip and the dislocated hip and the inverted Y appearance, which if you don't get, as I said, don't trust this ultrasound and ask for it to be repeated. Now, this is a very important. When I started the screening, I spoke about the clinical screening, and then there's obviously the ultrasonographic screening. Now, we can do hip ultrasonography to all the universal program for screening, but we can also select to do ultrasound for the babies at risk. These are the babies with the 5 risk factors we mentioned at the first slide, which is the female firstborn with a positive family history, born breech with associated clubfoot, or the babies who have a positive Barlow or Ortolani test. And remember that we mentioned that the positive test is the test that has a clunk and not a click. The second controversy is that we at birth, and we can perform it at 6 weeks. Now, we have to remember that this is a developmental and not a congenital condition. So a baby born with a stable hip, within 6 weeks, the hip might become unstable. And vice versa, a baby born with an unstable hip may stabilize at 6 weeks. So given all these facts, we have to remember that to have an ideal screening test, it should have a very high sensitivity and a very high specificity, resulting in nearly no false positive and no negative cases. A very typical example for a very successful screening test is the heel prick test for hypothyroidism that is done for every single baby born globally. Now, the consensus on DDH is that we do an ideal screening test, whether clinical or ultrasonographically, which means that if we do Barlow and Ortolani and do an ultrasound for every single baby that is born, we will still have late presenting cases. And this was the experience in countries that established this program, especially in Germany, Austria, and Switzerland. They ended up with babies detected at the walking age. So they reached the consensus that you do not screen for DDH, you do a continuous surveillance. What is meant by continuous surveillance is that every time a baby is examined at the child care center for weight checking, for vaccination, for any respiratory or GIT problem within the first year of life, always make sure to examine the hips, not us, the pediatricians. That's why it's very important to pass over this message to them. Now, what would be the ideal protocol for managing DDH? What I suggest is that we do universal clinical screening, which means that we do Barlow and Ortolani for every single baby born by the trained pediatricians. Then we do a selective ultrasound screening at the age of 6 weeks, not at birth, because we will then pick up all the cases that were unstable and stabilized and all the cases that were stable but then became unstable. But we do not do this for every single baby. We do it to the baby with at-risk factors or the baby with a positive Ortolani stroke Barlow test. You are faced with either two things. You either have a positive ultrasound and you will then treat the baby as we will mention shortly, or you have a baby who has a negative ultrasound. You will not detect that this baby does not have DDH until walking age, and you have to keep an eye by the clinical surveillance, as I mentioned, by the pediatricians. I do not wish to spend much time on the pathology because I know that we have a lot of time factors. But I would like to jump quickly into the treatment. Now, the aim of treatment is to maintain a concentric reduction and obviously to avoid complications. Now, in the first 6 months of life, we like to use splints. The splints were in the beginning, they were static, and then they are now dynamic, what we call the Pavlik harness. Now, the Pavlik harness allows active range of motion within a safe or a stable zone. It is less restricting and more convenient and more tolerated by the parents and the baby. Now, spontaneous reposition occurs, and I will dwell on this in a moment. And there is very little chance of AVN to the femoral head, which is our most dreaded complication. Now, it consists of the chest strap that has to be applied first, and then the feet stirrups that are attached. And then we put the hips in 90 to 120 degrees of flexion, and we secure the straps. Now, the trick is that when we put on the harness, do not expect this to be a closed reduction and the hip spike. The hip does not reduce immediately, because I have met many junior doctors who think that once you apply the harness, then the hip is now reduced and you have to maintain it reduced as you do in a hip spike. And no, the reduction happens gradually within a day, 2 days, 3 days, a week. It depends on how high the dislocation is and how early in life you apply the harness. But the trick is that you should not keep trying on the harness forever. After 3 weeks of applying the harness, you should then re-examine the baby clinically and do an ultrasound. And if after 3 weeks of applying the harness, the hip remains dislocated, then the harness should be discontinued and declared a failure. What to do next, we will dwell on in a moment. We have a lot of complications. Many of them we have never seen, and they are mostly related to prolonged and faulty wear. But the most important thing is to try and avoid AVN. You will not see AVN with a Pavlik harness unless you intend to tighten your harnesses to put the hip in extreme abduction, more than 60 degrees. The other complication that you might see if you insist on keeping the harness on for more than 3 weeks after the hip fails to reduce is the Pavlik disease, in which an erosion of the pelvis happens due to the persistently dislocated head. Now, how can we treat according to age? There's a lot of debate, but most of us will agree that in the first 6 months of life, we put on the Pavlik harness. But please remember, again, a take-home message, do not apply the Pavlik harness in teratologic hip dislocations. I mean in a child with, for example, arthrogryposis multiplex congenita, and do not apply the harness in a baby with either a flaccid or spastic paralysis. So do not put it on, for example, on a baby with meningomyelocele and a dislocated hip. It will not reduce. Or on a baby with a spastic CP with a dislocated hip, because the success of treatment with Pavlik harness depends on the normal muscle function. Now, closed reduction and hip spiker is really a very tricky procedure, because I find it very difficult to do a closed reduction successfully. Because to do a successful closed reduction, you need to have an adductor tenotomy and you need to do an arthrography. Arthrography is not easy, and it exposes both the surgeon and the baby to a lot of image intensifier and radiation. But anyway, if you decide to do a closed reduction, do it between the age of 6 to 12 months, because after 6 months, it's very difficult to use the Pavlik harness. And if you do it, make sure that you do an adductor tenotomy and make sure that you see a concentric reduction through an arthrography. You will not be able to depend on the plain X-ray through the hip spica. Now, to do an open reduction and hip spica, you can do it from as young as 6 months. I personally prefer to do it once the baby presents to me after the age of 6 months and it is impossible to put the Pavlik harness on. I do not like to go to closed reduction. Sometimes you need to do a femoral osteotomy if the hip has a residual hip dysplasia and it is mostly increased femoral anteversion. And sometimes you need to do a pelvic osteotomy if you have a residual acetabular dysplasia. Sometimes you need to do shortening if you have neglected cases with high dislocations. Sometimes you even have to do all the previous osteotomies together. Now, what are the complications of treatment? AVN, as we mentioned, is the most dreaded complication of all treatments. We have to remember that in the first 6 months of life, the circulation is predominantly end arteriolar with a little anastomotic overlap. And after 6 months of age, the medial circumflex femoral artery will provide the blood supply for the entire epiphysis and the physis. With so much of the proximal femur dependent on the medial circumflex femoral artery, if you abduct the hip in the extreme positions, you will compress this vessel and you will end up with AVN. So please remember, if you have ever seen a young lady 20 years old with neglected DDH who has not been treated at all, she will not have an AVN. But AVN in DDH is an iatrogenic complication. It has very variable reported instances in literature, and sometimes it may not be manifest except several years after your reduction, whether it is by the Pavlik harness, with a von Rosen splint, with a hip spica, or with open reduction. We would like to mention that if at 1 year after reduction, there is failure of the initial appearance or increase in size of the femoral head, or there is broadening of the neck, sclerosis or fragmentation of the femoral head, then you might very highly suspect that AVN is present, like many of these pictures show here. So sometimes you end up with no femoral head. This was either present and disappeared, or it failed to ossify at all. Ossification of the femoral head at the time of open reduction has been reported in the literature as being associated with a decreased rate of AVN. A lot of theories, vascular and biomechanical. However, to delay your reduction until the femoral head ossifies is debatable, because this may delay your reduction or your interference until the baby is aged sometimes up to 18 months. And obviously, this will increase your need for additive procedures like femoral or pelvic osteotomies. As I mentioned here, if you AVN in DDH is an iatrogenic complication. As I mentioned, the main cause is immobilization in extreme of abduction, lack of concentric reduction, which places increased pressure on the femoral head, sometimes concentric reduction under tension, that is, if you do reduction in neglected cases or high dislocations without doing a femoral shortening. Very rarely open reduction will cause this, and some people say that the medial approach is more commonly associated with the AVN, and that's why most of the people will say that the anterior approach is the safest. Again, I will skip the pathogenesis. Then I will go into the second most dreaded complication, which is the recurrence of the dislocation. In most so-called redislocations, the actual situation will reflect either failure of concentric reduction or failure of reduction at all. Now, in DDH, failure to obtain a stable concentric reduction after open operation is uncommon. And most of the cases of failure will be due to errors in the surgical technique. Most studies will report an instance of about 3% through the anterior approach, which means that every 100 hips that you reduce openly, 3 of them will end up with a recurrent dislocation. Not might end, they will end. And you have to explain this to the parents of the child very clearly. Now, how do we manage? A matter of debate, but again, the most practical way. If you have your redislocation early, which means within the first 3 weeks after reduction, then you should go in and solve your problem immediately. But if you get your redislocation after 3 weeks, then it's better to remove the cast and leave the baby out of the spica for 6 weeks to get a good range of motion, and then go in and do your revision surgery. Because one of the most dreaded complications of revision surgery is stiffness. Now, we have to differentiate between the immediate and the late dislocation. If you have an immediate failure of open reduction, the most common causes are: 1, dislocation during application of the hip spica. And that is why you have to attend every DDH that is done under your name as a pediatric orthopedic surgeon. You have to apply the hip spica yourself. I've trained many surgeons in doing open reduction of DDH, and I'm very happy when they have reached the high level of training to leave them to do this operation alone while I'm overwatching their shoulders or having a cup of coffee. But when it comes to the hip spica, I do it myself with them. Now, a coincident pelvic osteotomy. This is a matter of debate, but my personal experience, and it's present in the literature, if you do with your open reduction, pelvic or a femoral osteotomy, you increase the incidence of immediate dislocation because you have the proximal femur as a loose fragment. Now, if you have delayed failure of open reduction, it is usually due to you have not done good soft tissue release. And one of the most important structures that many people forget to release or do not know how to release is the transverse acetabular ligament, or you have done an inappropriate capsulorrhaphy. Okay? Now, a second, I don't know which number, but again, the take-home message from this lecture is all attempts to use an osteotomy, whether it is pelvic or femoral, to reduce a dislocated hip without achieving a concentric reduction are useless, because they do not address the problem of intra-articular adhesions, which is a constant finding. So you have to revise your open reduction and correct all the steps that you missed, and if you have any intra-articular adhesions, you have to release them, and then you do your capsulorrhaphy again, and then if you need a pelvic or a femoral osteotomy, you have to decide how to do it and when to do it. But you first have to have a concentric reduction. Now, in the revision operation, which is more difficult than the primary operation, you have to release the extensive adhesions which are around the periphery of the head. If your labrum is enfolded, you have to do radial incisions in it. Sometimes the whole acetabulum is closed by a sheet of fibrous tissue. Again, if the transverse ligament hasn't been divided, you should divide it. You should remove all the pulvinar that is in the acetabular fossa. And then sometimes you need to do femoral shortening, and then you should assess all your antiversions, and then you should redo your capsulorrhaphy. And as I said, if I need a video, I do not do it at the same session, I do it after 6 weeks. I never use K-wires in DDH, and I believe if you need K-wires to stabilize your hip, then your reduction is not concentric. But very rarely in the revision cases, even if after I've done all my steps, I'm still a little bit concerned, especially because I do not do the varus osteotomy in the same session, and this is the only situation when I will use K-wires to stabilize my reduction, but only after doing the capsulorrhaphy. Now, a very controversial issue is the late presenting cases. What to do? You have a big debate: interfere, leave alone, do one stage, do a staged surgery. Now, because of the long existence of the deformity, the achievement of a completely normal hip joint is virtually impossible. Now, DDH, if left untreated, will produce limping, will produce pain, stiffness, and finally progressive disability, and it will leave many patients crippled early in life. Although you cannot expect to give a normal hip to a neglected dislocation, but you will delay morbidity and give much more years of normal life, and you should also provide a local anatomic conditions should a total hip replacement be required in the future by one of your colleagues. Now, unilateral cases, most authors agree that reduction should be attempted and one should not rely on the possibility of future total hip replacement. Some authors prefer to perform open reduction as the only primary procedure unless you need a femoral shortening, reserving the femoral or pelvic osteotomy as a secondary measure. Their argument is that redislocation may complicate the combined procedures, so concentrate on doing a good open reduction. Now, bilateral cases, the older the child with bilateral hip dislocation is a very difficult problem. The risk of stiffness in both hips is very significant. At one point, I'd just like to go back to even in the early presenting unilateral cases, you will always get better clinical outcome if you have a left hip better than a right hip. If you have one hip dislocated, better than two hips, and in girls, you get better results than boys. Definitely in bilateral neglected cases, you will have increased risk of stiffness, and you might sometimes get asymmetric results, and the child ends up worse than if you had not treated her. So you should carefully consider treating bilateral dislocations in children between 5 to 8 years old. It will depend a lot on the body weight of these children and the level of the dislocation, and you speak a lot to the parents. You should withhold treatment. You should definitely withhold treatment in bilateral dislocations in children above the age of 8. I can assure you that even if you have excellent x-rays, you will have stiff asymmetric hips. So please do not try and treat neglected dislocations bilaterally in children above the age of 8 years. I hope I have covered most of the topic and I have stuck to the time. Thank you very much.
Thank you, Dr. Tarek. We will postpone the question till the end. We're going to have discussion at the end with some cases also. Now Inspire Company will have a presentation. اتفضلوا يا دكتور مصطفى، مين اللي هيقول البرزنتيشن؟
اوكي يا دكتور جمال، انا هقدم.
دكتور عمرو.
اتفضل يا عمرو.
اتفضل يا دكتور عمرو.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. في البداية أعرف بنفسي، أنا عمرو نصار، Associate Product Manager Inspire Pharma. الحقيقة يعني أنا عايز أكرر بالنيابة عن Inspire، عايز أكرر كل الشكر للجمعية المصرية لجراحة العظام على الحقيقة الجهد الرائع والمبذول طوال الفترة الماضية كلها regarding CME programs اللي بتقدمها لكل السادة الأطباء سواء داخل أو خارج مصر. شكرا لاختياركم Inspire Pharma انها to sponsor this valuable project. باختصار احنا Inspire Pharma we are national pharmaceutical company موجودين في السوق المصري منذ ما يقرب من 15 سنة تقريبا. لينا اكتر من 15 innovative product او بنسميها innovative solutions. يمكن from day one الاوبجيكتيف بتاعنا في Inspire Pharma دايما to fill the gap اللي موجودة في السوق المصري عن طريق ان احنا provide innovative solutions with guaranteed quality and affordable price. واحد من الانوفيتيف سوليوشنز دي النهارده او الانوفيتيف برودكتس دي هو the most recent new oral anticoagulant اللي بتقدمه انسباير فارما، هو البيكساسباير بسبان 2.5 مللي جرام paving the way with clean power. يمكن بنقول paving the way with clean power regarding the superior efficacy of Bixaspire or Apixaban versus the traditional anticoagulants with clean power regarding the favorable safety profile اللي بيقدمها البيكساسباير comparing with other anticoagulants. يمكن زي ما حضراتكم عارفين ان في important role للانتيكواجولانت بصفه عامه after الاورثوبيديك سيرجري، لان بنلاقي ان without VTE prophylaxis الدي في تي انسيدنس after الميجر اورثوبيديك سيرجري بتوصل ل 60% وممكن تتحول الى فيتال بالمونري امبوليزم واللي نسبتها بتوصل ل 3% after الالكتيف هيب ريبليسمنت or 7% after الهيب فراكشر سيرجري. معظم الحالات دي بنلاقي ان هي بتكون اسيمتوماتيك، لان every one patient have signs of DVT after total knee replacement. في قصاده 21 patient asymptomatic and every one patient have signs of DVT after a total hip replacement. في قصاده 5 patients asymptomatic. حالات الاسيمتوماتيك بروكسيمال DVT بنلاقي ان هي المين سورس لحالات الفيتال بالمونري امبولاي. على مدار السنين اللي فاتت كان في اكثر من ريجيمن استخدم وتم دراسته سواء افتر التوتال ني او التوتال هيب ريبليسمنت سيرجري از روتين بروفيلاكسس، بدايه من البلاسيبو مرورا بالاسبرين او اللو دوز هيبارين وانتهاء باللو موليكولار هيبارين اللي كان بيقدم ريلاتيف ريسك ريدكشن اولموست 52%. على الرغم من كده كان له كتير من الليميتيشنز سبيشالي في الكلينيكال براكتس. على راس الليميتيشنز دي بنلاقي ان هو بيكونوا سبكيوتينيوس انجكشن، فبالتالي بيبقى انكونفينينت خاصه للاوت بيشنت للبيشنت بعد خروجه من المستشفى، بيلاقي صعوبه ان هو يكمل على الانجكشن. بلس the adverse skin reactions at injection site بلس the side effect heparin induced thrombocytopenia، والحاله اللي بيكون مصاحب للهيبارينز بصفه عامه سواء اللو موليكولار ويت هيبارين او الانفراكشنيتد هيبارين. ويمكن عشان كده النوفل اورال انتيكواجولانت كان ليها يعني افكت قوي جدا، لانها ببساطه حلت كل المشاكل اللي كانت موجوده مع الهيبارينز كونها اتقدمت في صوره اورال ادمنستريشن، فبالتالي بقت مور كونفينينت سواء للان بيشنت او الاوت بيشنت. بتقدم الرابيد اونست اوف اكشن ذا سيم از الانجكشن، بلس الميكانيزم اوف اكشن بتاعها ان هي بتشتغل على الفري اكتيف فاكتور 10 بلس اكتيف فاكتور 10 which is كلود باوند، فبالتالي بتبقى سوبيريور عن الهيبارينز او اللو موليكولار ويت هيبارين، بلس ان هي مالهاش اي دور ان انديوسينج الهيبارين انديوسد ثرومبوسايتوبينيا. بيكساسباير ابيكسابان 2.5 مللي جرام. يمكن الابيكسابان زي ما حضراتكم عارفين هو موليكيول اتعمل عليه a lot of mega trials على بولز كبيره من البيشنتس. يمكن هنذكر منها ادفانس 2 ترايل اللي كانت بتقارن الابيكسابان فيرسس الانوكسبارين، عملت على اكثر من 3000 بيشنت افتر الني ريبليسمنت سيرجري واتنشرت في اللانست سنه 2010. الكونكلوجن باختصار كان بيقول ان الابيكسابان is more convenient and more effective عن الانوكسبارين 40 مللي جرام without increased bleeding. الستادي الثانيه كانت ادفانس 3 ستادي اللي اتعملت على اكثر من 5400 بيشنت. افتر الهيب ريبليسمنت، واتنشرت في نيو انجلاند جورنال اوف ميديسين سنه 2010. كان الكونكلوجن بيقول ان الابيكسابان was associated with lower rates of VTE without increased bleeding. ده بول اناليسيز اتنشر في جورنال اوف بون اند جوينت سيرجري سنه 2012. كان عباره عن ميرج ما بين التو ترايلز، ادفانس 2 اند ادفانس 3 ترايل. البول الكبيره كانت على اكثر من 8400 بيشنت. لقينا ان الابيكسابان بيقلل حالات الميجور في تي اي فيرسس الانوكسيبارين 40 مللي جرام بحوالي 50% تقريبا، بلس حالات الاسيمتوماتيك بروكسيمال دي في تي، واللي زي ما قلنا قبل كده ان هي الموست كومن. الابيكسابان بيقللها بنسبه اكثر من 66% فيرسس الانوكسيبارين 40 مللي جرام. يمكن النقطه المهمه هي السيرجيكال سايت بليدنج، يمكن ده ذا موست فيرد كومبليكيشن اللي بيقلقنا كلنا من استخدام الانتيكواجولانت افتر الاورثوبيديك سيرجري، هو السيرجيكال سايت بليدنج، لانها الحقيقه ممكن يبقى ليها نيجاتيف افكت على العمليه. لكن الحقيقه الابيكسابان بيقلل السيرجيكال سايت بليدنج بنسبه حوالي 25% فيرسس الانوكسيبارين، يعني اولموست 25% من البيشنتس بيقل عندهم السيرجيكال سايت بليدنج مع الابيكسابان فيرسس الانوكسيبارين. مقارنه بالاذر نواكس، الابيكسابان ده ميتا اناليسيز على كل الترايلز اللي كانت بتقارن النواكس فيرسس الانوكسيبارين، 12 في الجورنال اوف ارثروبلاستي سنه 2016. كان بيقول ان الابيكسابان هو الاكسبشن الوحيد from all NOACs which reduced the major or clinically relevant bleeding versus the enoxaparin. يمكن عشان كده الابيكسابان اخذ التراست من الانترناشونال جايد لاينز، سواء النايس جايد لاينز which recommended apixaban as an option of the prevention of venous thromboembolism in adults after elective hip or knee replacement surgery، وايضا الجست او الامريكان كولج اوف تشيست فيزيشنز which recommended apixaspire or apixaban using apixaban rather than alternative forms of prophylaxis in orthopedic surgery patients. في النهايه بنقول البيكساسباير paving the way with clean power. apixaban 2.5 مللي جرام هو the most recent new oral anticoagulant بتقدمه انسباير فارما لحضراتكم. بيقدم significant VTE reduction versus الانوكسبارين 40 مللي جرام once daily. بيقدم significant surgical site bleeding reduction versus الانوكسبارين 40 مللي جرام بنسبه 25%. recommended بالانترناشونال جايد لاينز سواء الاي سي سي بي او النايس. انسباير فارما بتقدم لحضراتكم البيكساسباير في صوره 30 فيلم كوتد تابلت، فبالتالي بينشور ذا مينيمم ديوريشن اوف بروفيلاكسس، بيضمن ان البيشنت بتاع حضرتك هيكمل الجرعه الوقائيه بتاعته لغايه اخر يوم. البيكساسباير جرعته يمكن زي ما حضراتكم عارفين بتبدا من 12 ل 24 ساعه افتر سيرجري بجرعه 2.5 مللي جرام توايس ديلي لمده من 32 ل 38 يوم افتر الهيب ريبليسمنت سيرجري، ومن 10 ل 14 يوم افتر الني ريبليسمنت سيرجري. ده شكل علبه البيكساسباير 2.5 مللي جرام افيلابل في الماركت. العلبه فيها 30 قرص 3 شرايط، سعر الشريط 89 جنيه و75 قرش. بشكر حضراتكم، ارجو ان انا ما اكونش اطلت عليكم يعني، ولو في اي اسئله هنستقبلها برضو ان شاء الله في الكيو اند اي زي ما تفضل وقال الاستاذ الدكتور جمال حسني. دلوقتي هسيب حضراتكم مع الاستاذ الدكتور جمال حسني. شكرا جزيلا يا دكتور، اتفضل.
شكرا يا دكتور عمرو طبعا على البرزنتيشن. يعني وي هاف تو ريمبر ان الدايجنوزس بتاع الدي في تي بعد عمليات العظم is very difficult لان more than 50% of cases are asymptomatic، يعني ما عندوش اي اعراض. يبقى difficulty in diagnosis. تاني حاجه difficulty in treatment. we have to remember ان ساعات يكون الفيرست برزنتيشن بتاع العيان pulmonary embolism and death. التريتمنت كتير من الاحيان بيؤدي الى بوست ثرومبوتيك سندروم، ودي كرونيك كونديشن بتعمل موربيديتي كبيره. يبقى عندنا difficulty in diagnosis difficulty in treatment، وعشان كده العالم كله انتهى الى ان هو الحل الوحيد لمشكله الدي في تي في عمليات العظام اللي هو البروفيلاكسس، انك تدي بروفيلاكسس. الابيكسابان طبعا اثبت الفعاليه بتاعته وان السايد افكتس محدوده جدا في هذه الاحوال. دلوقتي هننتهي الى المحاضره اللي بعد كده ان شاء الله للاستاذ الدكتور حسن البربري. اتفضل دكتور حسن.
كابيلاري ابيفيسز. عشان ما نضيعش وقت كتير، هي السكافي ليترالي هي عباره عن ان الكابيلاري فيبرال ابيفيسز بتتزحلق من فوق النك والشافت اوف ذا فيمر. هي بتتزحلق posteriorly and medially، وبتحصل لها شويه روتيشن internally. هو ده ميس نمر، لان احنا دايما لما بنوصف ديفورميتي المفروض ان احنا بنوصف الديفورميتي ديستال ان ريليشن للبروكسيمال. يعني المفروض ان احنا نقول ان السكافي ما هوش اسم صحيح، هو اللي بيحصل ان النك والشافت اوف ذا فيمر هم اللي بيتزحلقوا على الهيد اوف ذا فيمر، هم بيتزحلقوا laterally وانتيرلي وبيحصل لهم external روتيشن. ودي الديفورميتي اللي احنا بنشوفها، ان بنلاقي ان اللاج او الليمب كله externally روتيتد. طيب احنا لما نيجي نتكلم على الابيديميولوجي بتاع السكافي او سيت كابيلار فيبر ابيفيسيس، هو ما هوش حاجه نادره، هو الانسنس بتاعه 1 in 10,000 which is يعني حاجه ما هياش رير قوي. هو ده الموست كومن ديس اوردر بيأفكت الادوليسنت هيب. ولما نفكر في الديموغرافي بتاعنا، هو احنا لازم نفكر في الفيتامين دي ديفيشنسي، اللي هو في الريسنت ييرز بيقول ان هو ده كوندمد جامد قوي، من اهم الحاجات اللي هي بتعمل لنا السكافي. هي very common في الاوبيس children، males are more common than females، البلاك population اكتر كتير، وهي بتحصل في البري بيوبرتال ايج، يعني في البويز مور في الايج اللي هو 13 years والجيرلز في 12 years. لما نيجي نتكلم على الريسك فاكتورز، احنا عارفين ان هي مور كومن في الليفت هيب، يعني ما ننساهاش هي شبه الدي دي اتش، هي بتبقى بايلاترال في حوالي ربع الحالات. الريسك فاكتور زي ما اتفقنا الاوبيزيتي مهمه جدا، هي دي الموست امبورتنت ريسك فاكتور. في حاجات اناتوميكال فاريشن زي الاستابيولار ريتروفيرشن او الفيمورال ريتروفيرشن which is more common، بتبقى موجوده في الاوبيس children، وهي دي بتزود الميكانيكال ستريسز او الشير ستريسز على الفايزيال جراف بليت، ودي بتعمل لنا السكافي. حاجه مهمه قوي ان برضو الاوبليكوتي بتاعت الفايزيال جراف بليت نفسها. احنا الجراف بليت بتاعنا المفروض ان هو بيبقى هوريزونتال ساعه البيرث، ومع الجراف بيبتند تو بي يعني يبقى اوبليك شويه، فهو ده اللي بيخلي السكافي بيحصل قبل البيوبرتي لما يبقى الفايزيال جراف بليت اوبليك سنه. طيب احنا لما نفكر في الفسيولوجي او الباثوفيسيولوجي بتاعنا، هي بتحصل في الهايبرتروفيك زون. الهايبرتروفيك زون اللي هي المفروض نورمالي بتبقى حوالي بتكونستيوت 25% 20 to 30% من الثيكنس بتاع الفايزيال جراف بليت. هم لقوا ان في السكافي الهايبرتروفيك زون بتكبر قوي وبتوصل up to 80%، يعني بتاخد معظم الفايزيال جراف بليت، وهم عشان كده فسروا ان هو ده لاك اوف فيتامين دي بيمنع الاوسيفيكيشن، ومنع الاوسيفيكيشن بيكبر الهايبرتروفيك زون، بيخليها مور سسبتبل ان يحصل لي السكافي. الباثولوجي بتاعي زي ما اتفقنا هو اتس مور ليس لايك سولتر هارس تايب 1، ان الكابيتال ابيفيسيس بتتزحلق او الشافت بتتزحلق على الكابيتال ابيفيسيس. هي فرقها الاساسي من التروماتيك سولتر هارس تايب 1 ان هي معاها انزنس اوف اي في ان، مع انها حاجه جراديوال لكن معاها انزنس اوف اي في ان. الحاجه الثانيه البريوستيوم بتاعي بيبقى انتاكت في الكرونيك سكافي، ممكن يبقى انجرد في الاكيوت سكافي. الاسوشيتد كونديشنز دي بتهمنا قوي، اللي هم الاندوكراينال ديس اوردرز زي الهايبوثايروديزم، الهايبوجوناديزم، الجروث هرمون ديفيشنسي او البان هايبوبيتيوتريزم. كل الحاجات دي بتزود الانسنس اوف سكافي جدا. الداون سيندروم از فيري كومن يحصل لهم سكافي. من الحاجات المهمه قوي ان احنا نفكر فيها ان احنا لما نلاقي تشايلد اقل من 10 years، او لو حصلت في ولد اقل من 50th percentile كويت، يعني ولد رفيع قوي، لا لازم اعمل له اندوكراينال ورك اب، لان هو مش طبيعي ان يحصل اقل من 10 years ولا في ولد رفيع الا لو كان عنده اندوكراينال بروبلم. احنا في الاكزامينيشن بتاعنا يعني ازاي ما نفقدش حاله سكافي تبقى بيست which is very commonly missed. احنا بنلاقي ولد عنده pain antalgic gait، او عنده ترندنبرج جيت لو يونيلاترال، او وادلينج جيت لو بايلاترال. very common ان هو بيبريزنت بلي بين، وهو دي من الحاجات اللي بتخلينا نمس حاله سكافي. من الحاجات المهمه جدا ان احنا في الاكزامينيشن عندنا اللي هي الدريمان ساين، اللي هي لما بنعمل وكلنا حافظينها وعارفينها كويس قوي، ان لما ببتدي اعمل فليكشن للهيب بلاقي الهيب بيخش انتو اكسترنال روتيشن، ودي بتتفسر بحاجتين: ان انا عندي ساينوفايتس، فالمور كومفورتبل بوزيشن في الساينوفايتس مع الفليكشن ان هو يعمل اكسترنال روتيشن عشان يوسع الكبسول ويدابت مور فلويد، او عشان الامبنجمنت بتاع البروكسيمال ميتافيسيس بتاع النيك اوف ذا فيمر بيمبنج على ستابيلم وما عندوش حل عشان يقدر يفلكس ان هو يلف رجله لبره فيجيب سبيس يعدي فيه الميتافيسيس. الكلاسيفيكيشن احنا عندنا كلاسيفيكيشنز كتير قوي، ودي بتلخبط ناس كتيره. احنا عندنا الراديولوجيكال كلاسيفيكيشن، وعندنا الكلينيكال كلاسيفيكيشن whether stable او unstable، وعندنا التمبورال كلاسيفيكيشن اللي هي اكيوت وكرونيك acute on top of chronic. الكلاسيفيكيشن اللي هي acute وchronic واكيوت on top of chronic هي ملهاش قيمه خالص لا في العلاج ولا في المانجمنت بتاعنا، فهي مش مهمه، بس احنا نذكرها بالمره. الكلينيكال دايجنوزز اللي هي اللودر كلاسيفيكيشن از فيري امبورتنت. احنا بنقول لو الطفل ده قادر يويت بير ايفن ويز كراتشز، يعني قادر يمشي حتى بعكازين في ايده وقادر يعمل شويه ويت بيرنج، يبقى انا هنا I have a stable SCFE. ودي مهمه جدا. الستيبل SCFE المانج بتاعها اسهل، البروجنوزز احسن جدا. الانستيبل SCFE اللي هو مش قادر يويت بير خالص حتى بالكراتشز، هنا انا عندي هاير انسنس اوف AVN، ولما هعمل له بيننج انسايت ولازم احط 2 سكروز، او ناس كتير بتفضل ان تحط 2 سكروز. فالكلينيكال whether stable or unstable is very important. Lastly انا عندي اللي هي الديب تمبورال اللي احنا قلنا مش هتفرق معانا كتير في المانجمنت، لكن عندي اللي هي الساوثويك او اللي هي الراديولوجيكال كلاسيفيكيشن. احنا بنكمبير الهيد شافت انجل، يعني احنا بنشوف الانجل بين الفايزيال جراف بليت وبين الشافت اوف ذا فيمر بايلاترالي، ولو لقينا ان الديفرنس بتاعي بقى اكتر من 30 اقل من 30 ديجري بتصنف على انها مايلد، ومودريت لو من 30 ل 50، وسيفير لو اكتر من 50. دي مهمه عندنا في المانجمنت. لما نيجي نعمل اكس راي، هي دي حاجه بقى يعني مهم جدا ان احنا ما ننساهاش. احنا معظم السكافي لما بنعمل في الايرلي او اللي هي المايلد كيسز، او ايفن حتى في المودريت لما بنعمل اكس راي اي بي وميميز سكافي، انا هنا دي نورمال اكس راي ما فيهاش اي مشكله خالص، ولازم اعمل لاترال فيو عشان اديتكت السكافي. المشكله اللي بتقابل معظم الناس ان احنا لما بنيجي نصورهم البين اللي عند الطفل ما بيبقاش قادر يتحط في الفروج بوزيشن، مش قادر يعمل فليكشن وشويه الابدكشن. فالريكومندد ان احنا نغير التيوب، يعني نلف التيوب ونصوره لاترال فيو من غير ما نوجع الولد ونعمل له الفروج بوزيشن، عشان اللاترال فيو هو ده الدايجنوستيك اكتر بكتير قوي من
حسن. معلش حسن، ناس باعتين ان هم بيتكلموا انجليزي بس، فطالبين ان احنا نتكلم انجليزي.
اوكي I'm sorry معلش حاضر، انا عشان محاضره انسباير بتاعي. We have to do almost always in SCFE we should do a lateral X-ray. The problem that we face is almost always that patients with SCFE can't do a lateral frog X-ray because of the pain. This is a limiting factor to do the lateral view X-ray. We should change the position of the tube and not change the position of the leg of the limb of the child. We should do a lateral view with changing the position of the tube to detect early SCFE. This is a 13-year-old boy. As I said, to look at the AP view, here it's almost normal. But when we look at the lateral view, we can detect the SCFE. These are the radiological signs of the SCFE. We had widening with irregularities of the physis. We had loss of the concavity of the anterior femoral head-neck junction, which is very clear here. This is a bump. We should have here a concavity. The reduction of the height of the physis because it turned to be, it went back, and that's why it appears to be with less height. The height is reduced of the epiphysis, and this is a sign of a SCFE. A very important line is the Klein line. When we do a line in the superior border of the neck, it should cut the epiphysis. Loss of this line, when it doesn't cut the epiphysis, is a sign of a SCFE, like here. This is the Trithoan sign, or the Klein line, where we have this line, it cuts the epiphysis, and here it passes above the epiphysis, and this is a sign of SCFE. This slide shows most of the signs. This is the steel sign, where we have here a white shadow of the fallen backward capital head. We have a reduction of the height of the epiphysis. We have the very thick epiphyseal growth plate. Sorry. And lastly, this is the Klein line, or the Trithoan sign. These are how we measure the Southwick angle to detect whether it's mild, moderate, or severe. Lastly, in the diagnosis, we can do an MRI to detect the early or the pre-slip. where we have the growth plate is wide and there is edema in the metaphysis. We have a decreased signal on T1 and decreased signal on T2. This is how we can diagnose a very early slip or a pre-slip. Now we come to the management of SCFE. SCFE, the management is almost always surgical. It's not like other hip problems in children like DDH, where we have a conservative way, or in the Perthes where there's a debate to operate or not. In SCFE, we almost always go into operation. And the most common operation is the pinning in situ. Other procedures are the Dunn's procedure and the osteochondroplasty. And lastly, we can do osteotomies to make for the secondary deformities which were not corrected with the pinning in situ. The ideal position in stable SCFE is to do a pinning in situ. We use only one pin in stable SCFE. We may use more than one pin in unstable SCFE. The position of the pin should be central in the epiphysis, not in the neck. It should be perpendicular to the physis in both AP and lateral views. We should have 5 threads passing the physis and 5 millimeters away from the subchondral bone. We will go into some technical details how to do it. It's important to know that this is not a fracture. We need only one pin in stable fractures, in stable SCFEs. If it's a severe slip, we should go more anterior to be able to hit the epiphysis centrally. The more you have the slip, the more you have to go more proximal above the lesser trochanter, and you have to go more anteriorly to go into the center of the epiphysis. How do we do it? We have to think about 4 points. First, the position of the child, the planning of the surgery during the operation, and the surgical technique and the post-operative care. The position, we should do gentle transfer, of course, no traction and no reduction. We even put the limb in some slight external rotation. Even in the acute cases, it's not advisable to do some internal rotation to aim at some reduction, because this may increase the incidence of AVN. Once the limb is in a proper position, we should move the C-arm, not the limb, to have a good view, whether AP or lateral. This is how we use the C-arm. If possible, you can use 2 C-arms simultaneously, but I think it's not available here in most of our hospitals. How do we do the planning? The entry point. It's very important to have the proper entry point. It's like when you do fishing, you're trying to hit the center of the epiphysis, as I said. You should do 2 lines. The first line, you obtain a good AP and lateral view. You draw a line overlying the neck. It's not bisecting the neck. It's bisecting the head and perpendicular to the physis. And whatsoever how it goes through the neck, it's not important. I've been taught by my late professor that we should cover the neck with our hand on the screen and just draw the line to be perpendicular to the head. Forget about the neck. The problem with most of the orthopedicians is that they are used to pass the guide wire in the center of the neck, and this is completely different in the SCFE. We should be almost always oblique in the neck. The more the SCFE, the more you go more oblique in the neck to hit the center of the epiphysis. This is how we draw the lines. This is for the one for the AP view and one for the lateral. Where they intersect is the entry point. The entry point, we should do a 2 centimeter incision. And we should incise the iliotibial band in a good way to have freedom in moving the pin without any bending. This is how we do the entry point. The pin insertion, we should try to be only once. We may over drill the entry point or the nearby cortex to have freedom also in moving the pin. We should check the position of the wire. As I said, it should be centered in the epiphysis, perpendicular to the physis, both in the AP and lateral views. we should have 5 threads that pass the physis, and we should be 5 millimeters away of the subchondral bone. We should never place the screw unless we are 100% sure of the position of the wire. After insertion of the screw, we should be sure that it's not passing the subchondral bone. We have 3 ways to be sure of this: the approach withdrawal technique that I mentioned after seconds, and we should do the fluoroscopy with rotation 20 degrees increment, and be sure that there is no single view where the pin is less than 5 millimeters away with the subchondral bone. If we are in doubt, we can do a post-operative CT, and we should put the second screw inferior to the first one and check its reposition with the same methods. We should know that transient pin penetration is harmless. If I put a pin and I discover that it passed the subchondral bone, we can go on the next day and just pull it for 2 or 3 threads to be sure that we are aware of the joint. A transient pin penetration is completely harmless, while persistent pin penetration causes severe chondrolysis. The approach with the root technique, simply we look at the tip of the screw and its relation to the subchondral bone. In a fully extended limb, just we rotate the limb from maximum internal rotation to maximum external rotation. First, we will find that the pin is approaching to the joint, and then it gets away. This is the approach with withdrawal technique to be sure that we're far of the joint. This is an X-ray of a child with SCFE. As you see on the AP, it's almost normal. It could be missed. It's not 100% normal because here the trithean line is away of the epiphysis, but it could be missed. But on the lateral view, it's a moderate SCFE. And this is how the screw, as you see on the AP, it's central and perpendicular. It's central in the neck, while on the lateral view, it is going from anterior to posterior to hit the center of the epiphysis and to be perpendicular to the growth plate. This is after ephysiodesis. The post-operative, we should use crutches for 4 weeks. Normal walking is allowed from the 2nd or 3rd day. We should be aware of contact sport, no contact sport unless complete ephysiodesis of both sides, and we should do a follow-up X-ray every 4 to 6 months. We should remember that we should not try to do reduction, even in the acute cases. It's said that it's better to be fixed while the limb is in slight external rotation. The pin should be central to the epiphysis and not to the neck of the femur. We should be perpendicular to the physis in both the AP and lateral views. We should be 5 threads again that passes the physis and 5 millimeters away of the subchondral bone. Don't insert a screw except after you're sure that the wire is in a proper position, and check the screw position with 2 methods intraoperatively, and if in doubt, do a post-operative CT, and you may be allowed to do on the 2nd or 3rd day 3 rotations back of the screw is better than leaving it inside the hip. Our aim is physeal closure. We should do no screw removal until physeal closure. Follow-up on both sides is very important. A very recent mode of measuring SCFE is the open epiphyseal reduction and fixation, or the modified Dunn procedure. There is a lot of controversies concerning this procedure. It was very popular 7 or 8 years ago, and due to its very high complication rate, which approaches, it ranges from 16 to 37% AVN rate, it's not becoming very popular these days again. It has a very steep learning curve, and it should be done by a very expert surgeon. It's not advisable by any means to be done by young doctors or non-pediatric orthopedic well-trained surgeon. The idea of this operation is that we use an open approach, and then we do anterior capsulotomy. We surgically dislocate the head. We remove any callus, and we protect the vessels, we reduce the head, and we do fixation. This is very tempting, and it's very nice to be done. But the problem is that it has a very high complication rate, and as I said, it's not advisable to be done by anybody except a very, very well experienced surgeon. This is how the done procedure is done. Lastly, I have to talk about the osteochondroplasty, where after we do the pinning in situ and the episiodesis, we have an anterior bump or the metaphysis, which causes impingement over the labrum of the acetabulum. And this causes pain and arthritis if not treated. That's why it's advisable, if we have this bump, especially in moderate SCFE or on severe SCFE, we should do osteochondroplasty. We should go and remove this bump anteriorly, either arthroscopic, which is again needs a very high technically trained arthroscopic surgeon, or it could be done with an open reduction. The outcome of osteochondroplasty is very good if done in indicated cases, but as I said, it should be done with an experienced surgeon too. Thank you very much, and sorry for being a bit late.
Thank you, Professor Hassan. Now, we are going to listen to Professor Khamis Eldeeb. Professor Khamis, please.
Yes, sir.
Yes, Dr. Khamis. Professor Khamis.
Great. Oh, yeah, the presentation. الصورة واضحة؟ ما فتحتيش الميكروفون.
واضحة واضحة.
تمام. بسم الله الرحمن الرحيم. Dear friends, colleagues, brothers, sons, ladies and gentlemen. السلام عليكم ورحمة الله وبركاته. First, I'd like to thank Professor Gamal Hosni for kindly inviting me to share you this elegant scientific gathering. And my talk is about leg calvé Perthes disease. Let us recall the words of Mr. William Hazlitt, the very famous English philosopher, writer, and historian, who said, when a thing ceases to be a subject of controversy, it ceases to be a subject of interest. And by far, Perthes disease being the most controversial issue in orthopedic surgery, it is surely the most interesting. The most controversial item in Perthes disease is its treatment. Early writers believed that the final outcome of the condition is predetermined, and the disease runs a self-limited course of inevitable destruction of the hip. This is the opinion of Legg, 6 years after the description of the disease. So leave the patient alone. Everything is going to go in its way without your interference. This is his opinion. Evolution of treatment of Perthes disease is very interesting. I like to classify the treatment of Perthes disease into two eras. The first between 1943 till 1960, and the second era between 1960 till now. In the first era, when the disease started to be treated, the concept was that the femoral head is soft. So it's going to crumple under the stresses of weight bearing. So the concept advises weight relieving methods. Don't put weight over the affected limb. Weight relieving methods started very highly, severely done, bed rest, no walking at all, plaster spica, skin traction, and braces in position. Later on, the authors advised ambulatory weight relieving methods. The first and most strange is wheelchair. the second Snyder sling, the third weight relieving calipers. This is the opinion of one of the colleagues in Denmark, whose name is Jürgen Loritzen. He advised putting the child like this in a wheelchair. For how long? For a year or two. Is this possible, or this human from his point of view? He said yes. Snyder advised doing his sling, 2 crutches, and putting weight on the normal limb, of course, in unilateral cases. To avoid using crutches, Taylor advised this weight relieving caliper, raising the shoes on the normal side, and the foot is hanged in something like Thomas splint, and putting weight over the pelvis on the affected side. A surprise came after 4 main big studies compared the results of treatment of weight relieving methods to no treatment at all. The results were nearly the same. So treatment, no treatment. Coming to the second era, which started in 1960 by this great man, Robert Bruce Salter, he said that the femoral head is not soft in a physical sense, but it is biologically plastic. So it's like a firm dough, and it's going to take the shape of the acetabulum when it is put in the depth of the acetabulum, that is to contain the femoral head in the acetabulum. So the concept was that biologically plastic head using containment methods. To start with, conservative containment started, afraid of putting weight over again, using containment casts or braces. In bilateral cases, of course, we use the static containment, which is a brace like this, put in abduction and internal rotation, but still no weight bearing. Tashijian get some courage to use the same weight relieving caliper, but putting the hip in abduction. This is the Tashijian brace. And then they used another big splint like this, which is the Harrison, Turner, and Nicholson, putting the head in abduction and internal rotation, and using also, again, strange crutches like this. One of them is bent on the affected side. No weight bearing. Then they get more courage to say, we can put weight over the affected limb, but in certain position. James Gordon Petrie of the Hostel of Sick Children in Canada advised this type of plaster cast, which is called Petrie cast, bilateral above knee cast, and putting weight over using 2 crutches. So weight bearing on the limb, which is put in the abduction and internal rotation. Then in Toronto also, they introduced this type of splint, which is the Toronto splint, again putting the hip in abduction and internal rotation using crutches. In the United States, the Atlanta Scottish Rite Children's Hospital brace is a short brace. When I met Dennis Wenger, one of the inventors of this brace, I asked him, did you still use your Atlanta Scottish Rite brace? He said, no, it usually breaks and we dispensed with it. By the way, the disadvantages of all these conservative methods of containment, that these are cumbersome and also put psychological burden over these children in this growing age. Then surgeons get more courage and they decided to do containment by surgical means, after which children are allowed to walk in an ordinary way. The first trial was the subtrochanteric varus osteotomy, which is introduced by Somerville in England in the late 50s, taking a wedge from the upper part of the femur and closing the wedge, then the head is contained as it's shown in the sketch. And then after putting a Harris plate, the head is well contained in the acetabulum. Of course, the picture is very illustrative. Salter's innominate osteotomy was the second trial to get coverage of the head. But the Salter's innominate osteotomy has got a certain idea, which was designed mainly for TDH. It was actually a redirectional osteotomy and not a containment osteotomy, as Robert Salter said. The idea of Salter osteotomy was this: it is one of the most commonly used surgical procedures in the treatment of DDH and Perthes disease. Robert Salter initially introduced this osteotomy as a redirectional one to stabilize the reduction of congenital dislocation and subluxation of the hip, and was used later for the acquired subluxation associated with Perthes disease. We remind ourselves that it is originally a redirectional one, not a containment one. It entails anterior displacement of the distal pelvic fragment so that the two fragments are kept in the same line. Salter believed that the acetabulum is squinted anteriorly. So he used the osteotomy to displace the head anteriorly, the acetabulum anteriorly to cover the head. The osteotomy is kept closed posteriorly, so there is no lateral displacement at all. The graft is taken from the anterior part of the ilium and fixation by threaded rather than smooth pins. This is the strategies, a small journal in USA, and I asked Robert Salter to send me a copy of it, combined open reduction and innominate osteotomy for congenital dislocation of the hip. This is the dedication, Robert Salter, when he was young by that time. This is the dedication to Dr. Khamis Eldeeb with my best regards. And I'm going to show you the slides of Robert Salter. This is the sketch of the osteotomy, graft taken from the anterior part of the ilium, and the osteotomy between the greater sciatic notch and anterior inferior iliac spine, fixation by threaded wires. So no lateral displacement again. This is the incision centered over the anterior iliac spine, splitting of the iliac apophysis, securing the lateral octonus nerve of the thigh, which is usually present in the trench between the sartorius and tensor fasciae lata, subperiosteal stripping of the iliacus and abductors, and this is the greater sciatic notch with the view from inside. Tenotomy of the iliopsoas, the tendinous fibers, not the muscle fibers. And then this is the clamp, which is introduced from inside to outside to catch the giggly saw. Again, giggly saw was caught. Taking the graft from the anterior part of the iliac crest, reshaping of the graft, pulling the distal pelvic fragment anteriorly only, then putting the graft, and then putting the wires. So no, again, lateral displacement. Cutting the graft flush with the iliac apophysis, closure with thin stainless steel wires as something like plastic surgery. This is the picture after the osteotomy. He also applied half spica cast, and this is the picture after removal of the wires. In 1974, Professor Hassan and myself introduced some modifications to convert this to convert this redirectional osteotomy into a containment one that is designed to provide more anterolateral coverage of the femoral head in Perthes disease. We applied inferior tilting and anterolateral displacement of the distal pelvic fragment so that the distal fragment will not remain in line with the proximal one. So we opened the osteotomy site posteriorly to obtain lateral displacement. The graft is taken from the highest area of the iliac crest to keep the anterospheric spine palpable. This area is thick, that's why we use this thick part to maintain the displacement, which is need much force. The graft is put obliquely in order to maintain the anterolateral displacement. The graft is fixed to the two fragments by smooth pins, not by threaded wires. This is our sketch. Incision, the same. Splitting of the apophysis. Giggly saw introduced. The graft is taken from the highest point of the iliac crest, and this is the graft after reshaping. Osteotomy, greater sciatic notch, anterior inferior iliac spine. This is the osteotomy. Then we push the distal pelvic fragment by an impactor. Displacement is anterolaterally. See how we are opening the osteotomy site posteriorly. Graft is put obliquely like this. See how the displacement is there. And then we put the smooth pins. This is one of the cases, 3.8 years, bilateral Perthes. The left hip is somewhat contained. The left is still contained also. We waited for 3 months. After 6 months, you can see that the right head is subluxating and left head is contained. So we decided to do the operation. And this is after removal of the wires. Head is well covered. Left hip is okay. After 1 year, the right head is developing normally. The neck is gaining the usual length. The left side, the neck is short, but still contained. We asked the patient to come after 3 months to check. He came after 4 years with subluxation of the left hip. We told him that you need to have an osteotomy on the left side to cover this head. See how the right hip is developing normally. He didn't come again and came after 9 years. This hip is nearly destroyed, as you see. Very short neck, head is subluxated, and the right hip is completely normal. So is it necessary to treat Perthes disease? Yes, but we should have a system. We in Alexandria had our system, Alexandria system of treatment of Perthes disease. It's composed of 4 digits. The first digit is observation, wait and see, or let me say supervised neglect. Follow up the patient. This usually happens in children below the age of 6. We don't rush to do surgery unless we have some signs that indicate that this child will be operated upon. So children below the age of 6 years, regardless of the extent of the epiphyseal involvement, catarrhal 1, 2, 3, 4, or herring A, B, B, C border, and C, provided no subluxation, no limitation of hip movement, just wait and see. Every 3 months, we check. The second digit is that intermittent symptomatic treatment. Again, children below the age of 6 years of age who develop frequent episodes of hip irritability and limitation of movement. Here, we do bed rest, abduction, stretching exercises only for 2, 3 weeks, 4 weeks. Once relieved, we ask the child to lead normal activity. If not, we do short course of non-surgical containment by a cast or brace for 2 to 6 months. Definitive early treatment or containment, of course, absolute indication of active treatment, containment treatment. Catarrh 3 and 4 or hearing BC border and C in a child between the age of 6 and 9. We do immediate containment. Catarrh 1 and 2, 6 and 9 years, showing evidence of subluxation. Sometimes we see subluxation in these cases in catarrh 1 and 2. So long there is subluxation, we should do containment. This is a relative indication, children under the age of 6 years of age, showing evidence of subluxation or other two-head at risk signs. In these cases, containment can be achieved either by conservative or operative means. We in Alexandria like to go away and do Salter osteotomy and let the child lead a normal life. The last digit is that cases of Perthes disease presenting later than the age of 9, our policy is early stages, condensation and early fragmentation, no surgical containment, because the results were usually poor. As the results are usually poor, we prefer to do either conservative containment or arthrodiastasis. What is arthrodiastasis? It is joint distraction. And the first thing which occurs when the American Academy of Orthopedic Surgeons, we have seen two posters. The first was by Roberto Guarnero from Brazil using monofixator. The second by Nuno Lopes from Portugal, arthrodiastasis using Elizarov. This is the right hip, as you see, subluxated. This is the monofixator, as you see. Then reduction of the head, putting a hinge and let the child walk with flexion extension range of movement. See how the head is nicely contained and no collapse occur. Jamal Hosni, myself, Fadil and Mohammed Lakluk from Armenia published a paper in the Journal of Pediatric Orthopedics, arthrodiastasis of the hip. The Alexandria system of treatment, the last item, late stages, late fragmentation and reossification, Kayari osteotomy, no more existent, because I met the granddaughter of Kayari and asked her about the osteotomy of her grandfather. She said it has a very highly honorable place in the Museum of History of Orthopedic Surgery. Valgus osteotomy, as believed by Anthony Cattrall, to be indicated in hinged abduction only. Don't remove the part outside the head, but do the valgus osteotomy. Third, hip resurfacing, I have no experience in. Last thing, hip replacement, total, preferably HAC coated. This is a patient, 15 years old, with neglected Perthes disease on the left side. By that time, Mr. Ronald Fernon was attending in our hospital in Alexandria. And I asked him about his opinion. He said, well, we can do a total hip replacement. And I have the prosthesis with me, but I will not do it. Kindly do it, sir. I said, yes, I will do. This is after 9 years, head is stable. The girl is walking nearly normally. After 23 years, still, she can walk normally. Another case, 35 years old, neglected Perthes. I went to do immediately total hip replacement after 7 years, after 21 years. The smallest Deeb, Muhammad, my grandson, has the opinion to say thanks for listening to my grandfather. And I hope that you are not having this very kind attention of the audience. Thank you very much.
Thank you, Professor Khamis. And we are going to postpone the questions till the end of this session. Now I'm going to speak about the recent advances in treatment of pediatric hip problems in general. We have three main pediatric hip pathologies: hip dysplasia, leg calf Perthes disease, slipped capital femoral epiphysis. And we've been listening to the conventional treatment. Surely we have a conventional treatment. So if you have a case of DDH, or you have a case of leg calf Perthes disease or a slipped capital femoral epiphysis, you have to classify them and you have to follow the conventional treatment. So you have guidelines. So you don't have to think. If you have a slipped capital femoral epiphysis and it's less than 30% or 50% of displacement, you can do pinning in situ. If you have a leg calf Perthes disease and the patient is above 8 years old and herring type C, you can do saltal osteotomy. And you have a hip dysplasia, you can do open reduction. And if you fail, you can follow the instruction like Professor Tarek said, so you can do another trial of open reduction and you avoid the problems you had in the first operation. But is that true? That you have guidelines for each case? I want to show you some cases. If you have a DDH and you have 5 previous operations, you have open reduction, you have another open reduction, and you have avascular necrosis, and you have trochanteric osteotomy, and you have 5 previous operations. The patient is 6 years old. Can we tell the pediatric orthopedic surgeons, can you stop doing operation to this patient? You've got no choices to do to these patients. But if you wait, you have more migration of the upper femur. So I thought, if you wait for a couple of 3 years, you are going to have the head in the thorax. This is an unstable joint. And the head is going up and up. And you had 5 previous operations done by the pediatric orthopedic surgeons. There is no more to do. Again, if you have such a case, and the patient has the so-called safe surgical dislocation, and this is, the term safe surgical dislocation is nonsense. It looks like super operations, super hip and super ankle. It's nonsense. It just wants to give you the impression that the operations are done by magicians. And we don't have magicians in our profession. We have ordinary persons. They have complications, and you have percentage of success. And so they did safe surgical dislocation of such hip. And you have this picture at the age 14 years old. Limping patient, pain, pelvic obliquity with safe surgical dislocation. Again, Perthes disease in a 12 years old boy with pain, marked limitation of patient, of motion, of abduction, and limping. And this, you see the extruded segment, a big extruded segment with totally stiff hip and pelvic obliquity. What you have in your guidelines? You've got nothing to treat such patients from the guidelines. Perthes disease, and the patient had Salter and osteotomy, overreduction. It's successful overreduction, but totally stiff hip. Again, painful, limping, and pelvic obliquity. What are you going to do? What you have? And in such a patient, another patient with congenital short femur, proximal femoral focal deficiency. And the patient will tell you should have super hip operations. Unfortunately, we don't do super operations because we are less than average surgeons. We do only simple operations. We don't do super operations. If there are any super operations in the history of orthopedics. So again, we have three main pediatric orthopedic problems: dysplasia, Elbarbary, Perthes disease, and subcapital femoral epiphysis. Remember, the secondary osteoarthritis is not insignificant after these problems. And in this paper, with a long follow-up of such cases, the prevalence of osteoarthritis by the age 50, in DDH, 40 to 50% of cases. In Elbarbary, Perthes disease, more than 50% of cases. In a subcapital femoral epiphysis, 20% of cases. I'm going to speak about two solutions: hip osteotomies or arthrodiastasis. What's the value of hip osteotomy? Usually we have, in the hip osteotomy, we want to normalize the anatomy of the hip. We want to have normal biomechanics. So you have a pelvic osteotomy, femoral osteotomy, and pelvic and femoral osteotomy. We want to make a normal hip or simulate a normal hip. But we have another type of osteotomy. It's we have a salvage osteotomy. So you have a reconstructive, you want to simulate the hip, and another salvage procedure. You don't simulate the hip. Perhaps you displace the hip more than normal. And this is one type of reconstructive osteotomy. If you have a case of congenital short femur or proximal femoral deficiency, and you have such a case, you can do valgus osteotomy using this valgus or varus plate, whatever. I can use both of them. And this is an example of how you use it. You can use the regular ones, but those are easier, far easier, and help you to control the hip more. I have many cases done by regular plating or bent plates or external fixator or something. But this is the best one. Again, proximal femoral focal deficiency. And those are simple hip procedures. We don't do super operations. As I've told you, we are less than average surgeons in union. But we have limits for osteotomies. If you have a congenital short femur, proximal femoral focal deficiency, and the patient had been treated by limb lengthening, and you have this high dislocation, and almost you don't have a hip, you don't have an acetabulum. You see the acetabulum, you don't have an acetabulum, you don't have the ability to reconstruct this hip. In such a case, again, you want to do another open reduction after 5 previous open reduction and trochanteric osteotomy. Or this plastic hip after another 5 previous operations in a 13 years old girl. You want to do more open reductions, and you have avascular necrosis, coxavara. Do you want to do more open reduction in this girl with this plastic hip after too many previous open reductions? Again, this plastic hip after too many open reductions and osteotomies and pelvic osteotomies. Do you want to do more? If you have neglected fracture neck femur, I was in the American Academy before, and we were talking about neglected fracture neck femur. They talk about neglected fracture neck femur if you receive the patient after 24 hours. But this patient presented after 5 years of fracture neck femur, 2 years of fracture neck femur, 4 years of fracture fever. No one speaks about fracture femur after 1 year, 2 years, or 3 years. They all speak about 3 days, 4 days, or something. So we were talking about 2 different topics. So when we talk about fracture femur in our area, we don't talk about the same neglected fracture femur they talk about in Europe or in the States. Cystic arthritis, 13 years old girl with all cystic and absent head and neck. Again, as I told you, proximal femoral focal deficiency. Safe, the so-called safe surgical indications. Again, this is a vascular necrosis of the femoral head after treatment of fractured femur in a child with a vascular necrosis, subluxation, pelvic obliquity, and pain. Or the disease. Now we're going to talk about the salvage osteotomy. Salvage osteotomy, the so-called salvage osteotomy. We'll talk about pelvic support osteotomy. Pelvic support osteotomy is a very old operation. It's dated perhaps 190 years ago. And started with this type of operation, just valgus osteotomy. As you see here, just valgus osteotomy and pushing the femoral shaft medially. And Elizarov just added another osteotomy. Elizarov did not invent the pelvic support osteotomy. It's far beyond, far beyond. Just he added another osteotomy here. The value of this osteotomy is to correct the mechanical axis and to add lengthening to the operation. So simultaneously, the greater trochanter is repositioned to create sufficient leverage between its apex and the rotation axis of the newly formed support. Angulation of the proximal femur is well marked by the soft tissue bulk of the proximal thigh and displaces the large soft tissue mass laterally, which provides more normal appearance of the limb. Most of those people have a bulk on the lateral side. So when you do the pelvic support, the bulk disappears, which is very important for the girls. So in such a case, which I've shown you, the six years old, we did pelvic support osteotomy, and we overcorrected the patient. You see, the angulation here is something like 90 or 80 degrees, because we were afraid of the progressive loss of angulation, because the body treats this osteotomy or this displacement osteotomy as a malunited fracture. So in spite of doing this displacement, we had, you see, the correction. Within 4 years, we have this picture again. It's almost, we did nothing for the patient. So take care of recurrence. When you do the pelvic support osteotomy at a young age, you have to tell the patient that the patient will need another pelvic support osteotomy in older age. Like this patient. This patient had pelvic support osteotomy and we did revision. The operation was done everywhere, and we did another pelvic support at the age 21. Again, neglected fracture neck femur in such a patients, and we did pelvic support osteotomy. And unfortunately enough, in the papers, 2 papers, they advised to remove this femoral head because they think it's causing pain to the patient. And we never do this. We keep the head because perhaps the patient will need it for a graft later. So the follow-up, we have pelvic support osteotomy. For the safe, the so-called safe, which is quite unsafe, surgical dislocation, we did pelvic support osteotomy and displacement medially. And this was follow-up. Again, absent head and neck, osteotomy, another osteotomy down there, and 13 years follow-up, we have some shortening. And see how the patient walks. The way she's running, you see. And the way she squats. She has free range of motion, you see. Remember, After pelvic support osteotomy, we don't need another operation because the people, they always talk about if you need an arthroplasty. We don't need an arthroplasty. If you have a successful pelvic support osteotomy, we don't need an arthroplasty. Again, with such a patient, we had another proximal osteotomy and another osteotomy to correct the mechanical accident to lengthening. Arthrodiastasis, it's derived from the Greek word. Arthro means joint, dia through, and taxis, to stretch out. You see the arthrodiastasis here. The indications of arthrodiastasis, in some cases of Perthes disease, avascular necrosis, chondrolysis, neglected hip dislocation, unstable capital femoral epiphysis, and adolescent arthritic hip. You see a case of avascular necrosis that I've shown you, and in the follow-up, you see, just arthrodiastasis, see here, and we corrected the subluxation. And in such a case, we have an osteoarthritis. So we did osteotomy also, a varus osteotomy and arthrodiastasis at the same time. So we can combine the femoral osteotomy and arthrodiastasis at the same stage. What's the rationale of arthrodiastasis? Even when the hip is not weight-bearing, muscular contraction can generate forces across the joint that may exceed the body weight. These forces can cause the femoral head to deform. Joint distraction attempts to neutralize muscular and weight-bearing forces on the femoral epiphysis, induce new vascularization, and prevent femoral head deformation. An explanation for the anabolic effect of intermittent hydrostatic pressure in vitro and during joint distraction may be an increase in the nutrition of the cartilage. Another advantage of the distraction and the arthrodiastasis is improving the moment arm of hip abductors. So distraction arthrodiastasis performed gradually induces new vascularization in the tissues. The persistent joint space widening after short-term distraction suggests repair of the articular cartilage, which may be related to clinical improvement during the transient loading of the distracted joint. As in walking, there is an intermittent increase in the hydrostatic pressure. And this is a regular case of arthrodiastasis. This patient is 8.5 years old girl with severe or herring type C or Catterall type 4 and starting to have subluxation, as you see here, Perthes disease. And we did arthrodiastasis. Usually we do over distraction, about 10 millimeters over distraction. This is after removal. And you see this is before the, see? Immediately after the operation. And this is after 5 years. You see, this is before the operation, and this is 5 years afterwards. And the way she walks 5 years afterwards. She's getting older. You see the patient. And this is 5 years follow-up. You see AP and frog position. And this is 12 years follow-up. See the picture? This is before the operation, and this is 12 years afterwards. This is long-term follow-up of the cases treated by arthrodiastasis alone. Again, this is the patient of Perthes disease treated by Salter pneumotosteotomy. And the patient had 9 years old, and they had now totally stiff hip, painful pelvic obliquity. And we just did an arthrodiastasis, as you see here, over distraction, 10 millimeters more than the other joint, if you compare to the other joint. And you see afterwards. And this was long-term follow-up. Look to the patient. The patient walks. The patient, the way the patient walks, as you see, So in conclusion, arthrodiastasis is an advantage over conservative treatment. We consider it as a conservative treatment. Arthrodiastasis, with or without soft tissue release, is a valid option of treatment in cases with Perthes disease who would normally expect to have prognosis with conventional treatment. We published that the Professor Khamis showed us a publication about management of Perthes disease with arthrodiastasis and mobilization of the joint. Then we published arthrodiastasis without mobilization of the joint. And then we published and we compared both of them. We did comparison, both of them. And there was no difference. If you do this traction with mobilization, without mobilization. Theoretically, they said that it's better to do it with mobilization because so and so and so, but there was no proof clinically at all. It was just a hypothetical issue. Arthrodesis can be considered as a salvage procedure without altering the anatomy of the femoral hip joint. The real merit of arthrodesis, you don't disturb the anatomy. So if you fail and you have another option, please do it if you want to. We don't disturb the anatomy. For hip osteotomies, patient selection and correct indication are the crucial for successful outcome. Preoperative planning is crucial to avoid intraoperative obstacles and sufficiently address the patient-specific deformity. There are limitations for hip osteotomy. You have to know this, that we have limitations. In such cases, we have salvage procedure as pelvic support osteotomy, as indicated in such conditions. Early and mid-term results of Elizarov modifications of pelvic support osteotomy are encouraging, actually. Thank you. I think I've finished my lecture and we are going now to the discussions.
Hi. Dr. Gamal, thank you very much for your very, very illustrating lecture. Actually, it's a good collection of so many difficult cases that were treated by arthrodiastasis and pelvic support osteotomy. And I think the case of Perthes disease that was treated by Salter osteotomy, the age was 9 years when the operation was done. That's why she got all the complications that you did for her arthrodiastasis. And we said that we don't usually like to do Salter osteotomy after the age of 7 or 8, maximally 7 or 8. After 9 years, the results are bad. That's why we have chosen the arthrodiastasis for treatment of these cases. Actually, we are impressed by your results, and especially for the results of safe surgical dislocation, which I think, as you said, it will be changed to unsafe surgical dislocation operation.
There is nothing called safe operation. It's not in this lifetime. Perhaps in the second lifetime, we're going to have safe operations. We don't know.
Maybe.
Maybe, we don't know. Now we have questions. Questions for Professor Elbarbary. In light with the FRCS exam, I don't know, do you perhaps have X-ray images outlining the different radiological signs of SCFE and possible to explain the Kapner's sign and why they get cam lesions?
Sorry, because I don't know what you mean by the Kapner sign.
Me too.
But for the cam lesion, is that the metaphysis of the proximal neck hits the acetabulum or the labrum of the acetabulum during flexion, because the capital epiphysis slides backward, and the anterior metaphysis of the neck becomes prominent. Just when you do flexion, the metaphysis hits the labrum of the acetabulum, and that's why if it's causing impingement, we should do the removal of this bump, which is anteriorly, either arthroscopic, as I said, which is very difficult, or tempting. It needs a very good experienced surgeon, or through open approach, which is somehow safe. It's also technically difficult. As Professor Dr. Gamal said, the safe surgical hip dislocation, in our experience, is a catastrophe. Even if it's done with the best experienced surgeon, the AVN incidence is approaching 36%. And in the original paper of Dr. Gan done, it was 17%, which says that 1 out of 6 hips done with this safe hip dislocation is a catastrophe. It ends with a destroyed hip. Just when you see a child with this problem, you can stop doing any further surgery. That's why it's not safe at all, even with the most experienced surgeons.
Professor Hassan, thank you very much for your very, very nice lecture, actually. And I think the first time I heard the term not slipped upper femoral epiphysis, I heard it from Professor Hassan, slipped lower femoral epiphysis, lower femoral metaphysis. Because actually, as you said, the head is displaced posteriorly, and the femur has been displaced anteriorly. So it's slipped metaphysis rather than slipped epiphysis. The first question. The second is that you said that you put 2 screws. What's your opinion about those who insist on doing only 1 screw fixation?
Yeah, classically we should do only 1 screw, which is safe. It's not a fracture, and as you know, the slip is in a certain direction. Just if we use 1 screw, it's more than enough. Some surgeons prefer to do 2 screws in the unstable types. But for the stable, a child who can weight bear even with a crutch, it's enough to use only 1 screw. Especially in moderate and severe cases, it's very difficult to put more than 1. 1 is very hard to be done. Then to use 2, it's not indicated at all, except if you can do them in the unstable slips.
When you put the patient on the operating table, in what position you put the hip? In abduction, internal rotation?
No. This was one of the main causes that led to AVN. That most of the surgeons are used to do the reduction like the fractured neck of the femur, that we should do abduction, flexion, internal rotation. But when we do this, we put more tension on the retinacular vessels, and this may lead to AVN. It's said that even in the acute slip, where we can easily do a closed reduction, it's not preferable to do the internal rotation. Just put the limb in slight external rotation to have the retinacular vessels without tension. The aim is to fix the epiphysis in a position without having AVN at the end.
I completely agree with you about that. And one nice thing you said, that you try to introduce the screw from the anterior part at the base of the neck. And this is very, very important in order to avoid trial reduction, and you put it in the same position by putting the screw through the anterior part of the neck, directed posteriorly under image. Thank you very much, Hassan. We enjoyed actually your lecture. We are looking forward to hear more and more experience.
Was a great one. It was a great one, Hassan. Really, the tips and tricks of the operation of the in situ, it was really great. Now, Professor Tarek.
Yes,
you
sir.
spoke about the hip sonography and the importance of hip sonography. The real problem of hip
Yes.
sonography is over-treatment of patients, because Graf himself was treating type 2A sometimes. So aren't you afraid of over-treatment using Graf guidelines of hip sonography? طارق سامعني؟
لا بالتالي مش سامع حاجه كبيره.
الصوت بس كان راح ثانيه.
اتفضل.
جمال عيد السؤال.
Professor Gamal, can you please repeat the question? Yes. I heard about the over-treatment of ultrasonographically diagnosed DDH.
Especially because Graf himself is treating patients with type 2A sometimes. And starting from type 2B, which is quite questionable by many other authors, whether to treat or just to do follow-up, hip sonography more after 1 month or something. He was treating all the patients type 2B. What would you think?
My opinion on this is very clear, Professor. I only apply the Pavlik harness on the babies who actually have a subluxated or a dislocated hip. And that's why
type 3, only type 3 or 4.
Absolutely. Because as I said, the ultrasonography is very operator dependent. The angles, when you measure the angles and you measure the alpha and the beta, and you then put your baby in one of the grades, it depends on where you put your points and how you drew the lines. So there is a very high in-observer reliability. So what I do is, first of all, I never treat a baby before the age of 6 weeks, because often once a click is heard or even a clunk is felt, then an ultrasound is done and the Pavlik harness is applied very early. And as I said, we all know that it is a developmental condition and a lot of these babies will stabilize by the age of 6 weeks. So never treat before the age of 6 weeks and never apply a harness on just a dysplastic hip. I just follow them up. And when I say I follow them up, it's just skillful neglect. I do not advise the parents to put on double nappies or anything like that. I just repeat the ultrasound after another 6 weeks and see where we get.
Okay, because we have to remember that even with the Pavlik harness, we have an instance of avascular necrosis of the femur head.
Definitely, definitely. And actually the tolerance of the Pavlik harness is not that easy. I mean, to have a baby 6 weeks old with a Pavlik harness on 23 hours and a half a day, and the mother taking, every time she takes the harness off, she thinks that she's harming the baby. It's not that easy. So the compliance is not that high. So we only have to apply it when we're sure that the baby will benefit from it.
Thanks, Professor Tarek. Professor Khamis.
Yes, Professor Tarek, I'd like to ask you a question. What's your opinion about the Salter's open reduction and innominate osteotomy as he described? This is the first question.
Okay.
The second question is some surgeons try to do both of them at the same sitting, subtrochanteric varus osteotomy and Salter innominate osteotomy, and call it super containment, again super.
Yes.
What's your opinion about this super operation?
Okay. My opinion from practice and also from the literature is that I will never do a combined procedure at the same time. I believe that doing a pelvic osteotomy or doing a femoral osteotomy at the same time as the open reduction definitely jeopardizes my capsulorrhaphy, which is the key of success. Right. And as time has gone past in my learning curve, I have actually raised the age of doing even a staged procedure. So what I have found is that even babies up to the age of 4 years, if you do a good, successful open reduction, you will find that as time goes by, the acetabular display, you end up with just a slightly steep slightly acetabulum. And if you follow up these babies as time goes by, the coverage gets much better. And actually, there is, until now, there is no definite evidence in the literature that if you have a contained hip that is just slightly dysplastic, that you will end up with premature osteoarthritis that will actually affect the function of these babies. No long-term outcome study has been done. So what I really do is that I concentrate very much on doing a very successful open reduction and not going into recurrent cases. And then only after follow-up, if there is any sign of a very early breaking of the Shenton's line, then I will go in and do just a derotation osteotomy, not a varus, because in the DDH, the problem is the increased femoral anteversion, not really a valgus hip.
Thank you, Professor Tarek. You are clear and illustrative and informative as usual. Thank you very much.
Thank you very much.
Professor Khamis, you said that you opened the
osteotomy site posteriorly. Yes.
Don't you think when you open the osteotomy posteriorly, that will increase the pressure over the head?
We do both things.
Which is a real problem in Perthes.
Yes, yes. One of the steps of the operation before we do Salter osteotomy is to do adductor tenotomy and iliopsoastenotomy. And this will lessen the pressure on the femoral head that resulted from the lateral displacement, actually. And by the way, none of our cases have had any avascular necrosis of the femoral head.
Okay, thank you. Professor Khamis, the last question for me, you prefer hinged distraction or non-hinged distraction? We started with hinged distraction using the orthofix. And after a few cases, we noticed that we taught the patients, we taught the families how to do hinged distraction. But after some time, we noticed that the patient, they don't do any movement. So it was just nonsense. So we started to do non-hinged distraction using cheaper Elzarov things.
Yes.
And with some time, we noticed that it's almost the same. On the people they spoke about the hinged distraction, they presented very few number of cases. And even they presented their experience in treating type A patients, herring classification, in the age less than 6 years, which is usually we have the best results if you do nothing for the patients. So that's why we shifted to the non-hinged distraction in the patients older than 8 years old, type C herring classification, all the patients that you are expecting poor results from the conventional treatment. Now we published it 2012, about 8 years ago.
Yes.
And he speaks about another question about the containment. If you have 5/8 of coverage of the femoral head, in such a case, we do abduction to get full coverage. If you fail to get abduction, we do adductor tenotomy. I think now we have no more questions. Finally, I would like to thank Professor Khamis for such a great participation. Professor Hassan Elbarbary, thank you so much for this illustrative lecture. Professor Tarek for this great lecture. And I would like to thank Inspire Company for their great support, especially my friend Mustafa Knawi, Dr. Mustafa. Thank you so much for coming and seeing you in such an occasion. Thank you,
Dr. Tarek. Thank you.
Professor Dr.
Excuse me, Gamal, I'd like to add something, Dr. Mustafa.
Yes.
Apixaban is used in the treatment of corona simply because one of the diagnostic procedures of corona is to do CT chest. And my brother had a subpleural infarct. That's why the treating doctor asked him to take apixaban twice a day. And he is now improving and going to the better. So please add this in to your pamphlets on my responsibility.
هو البلد كلها دي بتعمله في الكورونا.
good notes دكتور خميس but
اهم موضوع دلوقتي اهم موضوع دكتور مصطفى.
It is a long process with the Ministry of Health to modify the NCT leaflet of any drug at Egypt, because this modification must become firstly from the origin of the drug, I mean from FDA or from EMA. Then the Egyptian molecule will be able to do that.
Okay.
At the end of this successful, fruitful session, I would like to thank all speakers today for the brilliant talks and elegant presentation. I would like to thank Professor Dr. Gamal Hosni, Professor of Orthopedic Surgery, Banha University, and the current President of Egyptian Orthopedic Association, Professor Dr. Eldeeb, Professor of Orthopedic Surgery, Alexandria University, and Professor Dr. Hassan Elbarbary, Professor of Pediatric Orthopedic Surgery, Cairo University, Professor Dr. Tarek Hassan, Professor of Pediatric Orthopedic Surgery, Ain Shams University. And I would like to thank all attendees for their interactive participant discussion and participation. At the end, I hope to meet you all in the near future. Thanks again, and God bless you all. Thanks. Thank you very much.
شكرا يا دكتور مصطفى. ان شاء الله هنقابلك في مؤتمر الديفورميتي.
ان شاء الله يا فندم، موجودين ان شاء الله، حاضرين
باذن الله باذن الله يا دكتور جمال.
8 و9 اكتوبر
ان شاء الله يا فندم
جميعا.
ان شاء الله نكون متواجدين مع حضرتك.
عارفين التفاصيل يا دكتور جمال قبل حضرتك.
كل حاجه عنها.
شكرا
على خير. شكرا. مع السلامه.
شكرا.
Thank you very much.